Hello and welcome to the second webinar in our Calprotectin webinar series. My name is Aleksandra Havelka, and today I have a pleasure to talk about the role of calprotectin in COVID-19. I will start with a short introduction about the biomarker calprotectin, and then continue with some facts about hyper-inflammatory host response in COVID-19. Thereafter, I will present results from some of the recent studies related to the value of calprotectin in COVID-19. And lastly, I will present our product, GCAL, the immunoassay for quantification of calprotectin in human serum and plasma. So calprotectin belongs to a protein family called S100 protein family. It exists as a biologically functional heterodimer of two proteins, S100A8 and A9, also known as myeloid-related protein 814. Calprotectin is part of the innate immunity and is a key alarmin released in a first-line immune defense by neutrophils, monocytes, and macrophages. In neutrophils, calprotectin accounts for 40 to 60% of the cytosolic protein content. Calprotectin is released upon activation in neutrophils without any need for the de novo synthesis, and as such, calprotectin is early biomarker for neutrophil activation and bacterial infection earlier than other conventional biomarkers such as C-reactin protein and procalcitonin. In order to prove this early kinetic of calprotectin, we have performed an experiment in collaboration with University College of London, where healthy volunteers were injected with one single low dose of endotoxin. As you know, endotoxin is a component of the cellular wall of gram-negative bacteria and one of the most important components contributing to the inflammatory process. So once the inflammatory process started by injection of endotoxin, the kinetics of several proteins in these healthy volunteers were followed. So we have measured calprotectin, C-reactive protein, and procalcitonin, and have seen that increase in calprotectin concentration starts approximately 1.5 hours after injection of endotoxin. Calprotectin levels reached a peak at 4 hours post-injection, and after that started to decrease and were normalized at 24 hours post-injection. The increase in CRP was much slower, starting somewhere between 8 and 24 hours and reaching a peak at 24 hours. The level of CRP was still high at 48 hours after injection of endotoxin. PCT started to increase several hours after calprotectin, with the peak levels at 8 hours and slow decrease in concentration, which was normalized at 72 hours post-injection. Upon release from activated or consumed neutrophils, calprotectin binds mainly to two types of receptors, toll-like receptor 4 and RAGE receptor, which are both involved in pro-inflammatory signaling cascade leading to activation of NF-kappa B and production of cytokines, chemokines, reactive oxygen species, calprotectin, resulting in a pro-inflammatory feedback loop. This signaling pathway that I just described is activated in sepsis, contributing to dysregulation of the immune response in septic patients. Recently, a paper published in Journal of Korean Medical Science showed that the same pathway is activated in hyperinflammatory response in patients with severe COVID-19, and that calprotectin was found to be most highly increased inflammatory mediator in patients with severe COVID-19. The challenge in patients infected with SARS-CoV-2 virus is to early identify patients who will develop severe form of the disease. The role of calprotectin in early identification of neutrophil activation and hyper-inflammatory response in COVID-19 and COVID-19 related sepsis has been confirmed in several studies. Therefore, calprotectin may be used as a valuable biomarker for early evaluation of the disease severity and identification of patients at the risk to progress to severe form of the disease, contributing to effective triage and care of COVID-19 patients. COVID-19 is a disease with heterogeneous clinical appearances, mild for some and deadly for others. The majority of affected individuals exhibit no or mild to moderate symptoms, but up to 15% of patients develop severe pneumonia and approximately 6% progress to acute respiratory distress syndrome, septic shock, and multi-organ failure. Approximately 1/4 of subjects hospitalized with COVID-19 associated pneumonia require respiratory support in an intensive care unit, which is highly correlated with mortality. Several studies have shown the value of calprotectin in differentiation between mild and severe form of COVID-19, as well as in risk stratification and prediction of need for mechanical ventilation, admission to ICU, organ failure, and mortality. I will now present results from some of these studies. One of the first studies about calprotectin in COVID-19 was published by Shi and colleagues in Journal of Leukocyte Biology, demonstrating the value of calprotectin in differentiation between mild and severe form of the disease. Calprotectin was measured in 172 hospitalized patients and 47 healthy controls. COVID-19 patients had significantly elevated levels of calprotectin in the blood compared to healthy controls. Calprotectin levels correlated well with change in oxygenation status. In patients who improved, levels of calprotectin were decreased during hospital stay. Calprotectin levels were stable in patients with stable oxygenation status, and calprotectin levels increased in patients who become worse. Calprotectin levels were also significantly higher in patients who progressed to severe COVID-19 and required mechanical ventilation. Calprotectin also correlated with other acute phase reactants, including C-reactive protein, D-dimer, ferritin, and LDH, but was superior to other biomarkers in identifying patients requiring mechanical ventilation. A study published by Sylvin and colleagues in Cell confirmed the values of calprotectin in differentiation between mild and severe form of the disease. In this study, they have shown increase of circulating neutrophils in severe form of the disease. They have also shown that patients with severe COVID-19 accumulated non-classical monocytes and immature neutrophils in their blood and lungs. They have also reported increased expression of S100A8 and A9 mRNA in patients with severe COVID-19, and that calprotectin was the most significantly increased circulating biomarker compared to 24 other biomarkers with elevated levels in severe COVID-19. Patients with severe disease exhibited dramatically higher calprotectin levels compared with patients with mild COVID-19 or controls, and calprotectin levels were higher in patients with comorbidities, including diabetes mellitus, obesity, cardiovascular and respiratory diseases, and cancer. Induction of calprotectin and appearance of abnormal neutrophils were confirmed in a study published by Guo and colleagues. In this study, they have reported upregulation of S100A8 proteins in animal models and in COVID-19 patients. They confirmed that overactivation of calprotectin, toll-like receptor 4 signaling, results in immune imbalance and expansion of abnormal immature neutrophils during SARS-CoV-2 infection. They have also reported that an inhibitor of calprotectin, paquinimod, suppressed the accumulation of abnormal neutrophils and improved health status of SARS-CoV-2 infected mice, highlighting new opportunities for therapeutic intervention. The role of calprotectin in risk stratification and prediction of inferior clinical outcomes was confirmed in a study published by Shen and colleagues. In this study, serum levels of calprotectin were strongly correlated with the severity of clinical manifestations, and they had great predictive power for the risk for ICU admission and mortality. Circulating calprotectin levels were higher in ICU patients than in non-ICU patients, and also in non-survivors compared to survivors. We have performed 3 studies with our product, GCAL, in order to evaluate the performance of the assay in evaluation of the disease severity and risk stratifications in patients with severe COVID-19. One of the studies was performed in collaboration with Akademiska Hospital in Uppsala in Sweden, where calprotectin levels were compared in patients admitted to ICU with severe COVID-19 and in cancer patients admitted to the same ICU. Calprotectin levels in severely ill COVID-19 patients were significantly higher than in cancer patients admitted to the same intensive care unit. Calprotectin was able to distinguish between severely ill, non-COVID and COVID-19 patients with great sensitivity and specificity. Calprotectin levels correlated with other biomarkers associated with severe COVID-19, such as C-reactive protein, ferritin, D-dimer, lactate, and E-selectin. Correlation with E-selectin indicated the potential role of calprotectin in prediction of damage of endothelial cells and subsequent organ failure. The correlation between calprotectin and risk for organ failure was confirmed in a study performed in collaboration with Charité University Hospital in Berlin, where calprotectin was studied in patients presented at an emergency department. The aim of this study was to investigate whether increase of calprotectin occur prior to the progression to severe disease and therefore may be detectable already at an early stage of COVID-19 disease. Calprotectin levels in patients presented to the emergency department were significantly higher in patients who were admitted to intensive care unit, in patients who develop multi-organ failure during first 72 hours, and also in patients who developed multi-organ failure during whole hospital stay. In prediction of multi-organ failure, calprotectin performed better than other proteins, such as C-reactive protein, procalcitonin, and lactate. The role of calprotectin and performance of GCAL assay in prediction of mortality and need for mechanical ventilation were investigated in a study published in collaboration with Santa Lucia Hospital, Cartagena in Spain. In this study, calprotectin was measured in patients presented at emergency department in Santa Lucia Hospital. And the aim of the study was to investigate if calprotectin could predict need for mechanical ventilation and mortality in patients with severe COVID-19. Calprotectin levels were higher in non-survivors than in survivors and correlated positively with other biomarkers such as ferritin, CRP, GDF15, and D-dimer. Calprotectin showed good discrimination capacity for in-hospital mortality, which was comparable with the performance of GDF15, D-dimer, and CRP, but numerically was higher than performance of ferritin. Performance of calprotectin in prediction of mechanical ventilation was compared with performance of CRP and ferritin and D-dimer. So calprotectin, CRP, and ferritin were able to predict need for mechanical ventilation, but not the D-dimer. So in summary, in this study, only CRP and calprotectin were able to predict both need for mechanical ventilation and mortality and perform better than ferritin and D-dimer. A recent review and meta-analysis have summarized research results related to calprotectin and its performance in COVID-19, with the conclusion that calprotectin is a foremost candidate biomarker for COVID-19 infections, with both diagnostic and prognostic significance. Recent evidence suggests that calprotectin offers a potential therapeutic strategy in severe COVID-19 as well as other inflammatory diseases. So in summary, the calprotectin can be a valuable tool for estimation of disease severity and risk stratification for effective triage in care of COVID-19 patients. Calprotectin has been shown in several studies as a good discriminator between mild and severe form of COVID-19 disease. Calprotectin was also shown to be able to predict need for mechanical ventilation and ICU admission, as well as to predict multi-organ failure and mortality. Gentian's calprotectin immunoassay is particle-enhanced turbidimetric immunoassay, which can be performed in human serum and plasma samples. The test takes only 10 minutes and it's rapidly performed, can be applied on a wide range of automated clinical chemistry analyzers. In GCAL, we have used avian antibodies to improve animal welfare and decrease interference with rheumatoid factor and human anti-mouse antibodies. GCAL product is CE marked and available on the market since 2017. Thank you very much for listening. If you have any questions related to the content of this webinar or any other questions related to Gentian's products, please feel free to contact us at marketing@gentian.com. Thank you.